Hello everybody, welcome back to the CTO Demon channel. Today another core curriculum talk, and we're going to talk about what happens after we complete reverse cut. Now this is a topic that's not often talked about. The reason is, we all know when we manage to get a microcatheter across the retrograde channel into the distal true lumen of the CTO vessel, our success rate goes up tremendously. 95, maybe even 98% of those cases will be successful. And if we completed reverse cut, our success rate goes even higher. Almost all the cases when we completed reverse cut is successful. In the APCTO Club CTO registry, there's only 4 cases that we failed after successful reverse cut. So nobody really thinks about what happens after successful reverse cut, because everybody thinks, yay, we are successful. We don't need to do any more. But there is this little gap between reverse cut and antegrade wire access. Now, once we get antegrade wire access, of course, everything is like routine PCI. We just push things down, balloons, then imaging, whatever we want to do. But there's this gap between what is very familiar, which is routine PCI, and what is moderately familiar, which is reverse cut. Now, this gap has several problems that make it difficult. One, of course, the retrograde wire after successful reverse cut can fail to wire through the proximal vessel due to diffuse disease, due to tortuosity, due to dissection planes. Secondly, the retrograde wire can fail to wire into the antegrade guiding. And of course, finally, the retrograde microcatheter can fail to cross the CTO body. And then, of course, there are some niche problems, like if the patient is very, very tall and you can't get the retrograde microcatheter all the way into the antegrade guiding, or if you're doing an ipsilateral single guiding retrograde PCI. We don't recommend that, but sometimes you might be stuck with doing that. So this talk really is to cover all of these topics. Now, this talk was actually commissioned by Dr. Paul Gao for me to write this paper, and we wrote it together. The whole APCTO Club was involved in this, and we wrote the paper From Reverse Cut to Antegrade Wire Access, a guide to externalization, tipping, rendezvous, and snaring from the APCTO Club, and it's published, and you can see the link in the description below. Now, before we begin with all this, we need to talk about the default wire externalization method. Okay, after we complete reverse cut and the retrograde wires in the antegrade true lumen, the default method is to manipulate this retrograde wire to wire the antegrade guiding catheter. I want to push it into the antegrade guiding catheter, and then on the antegrade catheter, we're going to put in an anchor balloon. You can use a Kuklabi, you can use a 2.5 balloon, and you blow it up to trap and anchor the retrograde wire. With that anchoring, we can push the retrograde microcatheter across the CTO body into the antegrade guiding. Then we deflate the balloon, and we can begin externalization. We can pull the retrograde wire out and put an RG3 out and push it all the way through. Now at this point, there's an option to push the anchor balloon forward to anchor the retrograde microcatheter. This has the advantage of, one, stabilizing the system, because sometimes the heart beats and the retrograde channel moves and the retrograde microcatheter falls back out of the antegrade guiding. But with this anchor, it's all very stable. The second advantage of the anchor is that it could provide hemostasis, so that when you get the retrograde wire out and try to wire through the wire connector, it doesn't keep bleeding. So the final step, of course, is getting the retrograde RG3 through the antegrade wire connector. To do this, you unscrew the wire connector and you back it off the wire. And if you have an anchor balloon, of course, the wire and the antegrade balloon. Then you put a wire introducer through the hub of the wire connector. And then this takes a little bit of difficult manipulation. You manipulate the retrograde RG3 tip with your hands into the tip of the introducer. And you push the introducer along with the wire connector back and screw it together. And then you push the RG3 wire out and remove the introducer, and you've got antegrade wire access. So this is the default method. This default method is very good because, one, it provides very strong wire tracking forces for delivery of antegrade devices. And two, it's very secure. You never stand a chance of losing the wire position. So we should do this whenever we can. Now, there are 2 main reasons why we might want to not do this, or after we do this to switch out to antegrade wire more quickly. Number one is if we need to stent beyond the entry point of that retrograde channel. So this happens most often in LAD CTOs when we're crossing a septal channel from the PDA. Because often the septal channel enters in the mid-LAD and there's disease beyond the mid-LAD in the distal LAD. So what we should do is, after we've externalized, we pull the retrograde microcatheter back into the septal and we put on antegrade on the RG3 a dual lumen catheter. With that, we can then wire the distal LAD and we can remove the retrograde system and start stenting. The other reason for getting antegrade quickly is that if you have some trouble with the retrograde, say you're going through an apical channel and it's causing a lot of ischemia, patient's uncomfortable, or you've done something bad to the retrograde channel and you've got a perforation to deal with. Those would be situations where, or you have a donor artery problem, you're getting ischemia on the donor LAD or something like that, that you need to deal with, and you need to remove the retrograde system quickly, then that would be a case where we would quite quickly change back to antegrade wiring. So let's now address each of the component of trouble between reverse cart and antegrade wire access. First is the retrograde wire fails to wire through the proximal CTO vessel. Now, this is usually because the wire is trying to wire through a very tortuous vessel, or the vessel is diseased, or the wire is very sharp and it's got caught in dissection planes or in the plug. The best method to deal with this is to put a guide extension catheter down so that to the proximal cap, so you can just wire right into the guide extension, and the guide extension is going to prevent the wire getting into the subintimal space, getting into plaque in the proximal vessel. This was first described by Mozart et al. In their paper. If we can't get the guide extension to the proximal cap, we can always use a big balloon, even a 3O balloon, to dilate the proximal vessel to drag the guide extension down to the proximal cap. And this solution really solves the problem of retrograde wire getting past the proximal CTO vessel. The second problem is we fail to wire the antegrade guiding. The most important thing we need to learn about this is manipulating the retrograde wire is not a good way to wire the antegrade guiding. I repeat that. Manipulating the retrograde wire is not a good way to wire the antegrade guiding. Usually in everything we do in PCI, moving the wire is the way forward, but not in this case. Because the retrograde wire is difficult to control when it's gotten to the antegrade CTO os, vessel os. So it's difficult to control the wire. And what we need to do instead is to manipulate the antegrade guiding catheter. So often I will push the retrograde wire and look at what position it's in, and I'll try to manipulate the antegrade guiding to cover that position, and then I push again. So there are several tips and tricks. One is if you can get coaxial guiding position, that's much better. So if you're using an AL guide for an RCA CTO, changing it to a JR might make the life a lot easier. Using a guide extension, you can put a guide extension into the proximal vessel, making it much more coaxial and easy to wire. Another way you can do it is you can push the retrograde wire all the way up the aorta as far as possible. This is going to give more track on the retrograde wire, and with that, hopefully, enough to push the microcatheter through the CTO body. And if you can push it through the CTO body, you can switch out then for a more controllable retrograde wire, something like a C-on black wire that you can get big shape on, that you can wire the guiding. Of course, if you can't push the retrograde microcatheter through the CTO body, you can try to change for a rotational microcatheter like a Corsair Pro XS or Turnpike LP that you can rotate through the CTO body, and then you can switch wire. Because once you can switch wire and you don't have a stiff CTO wire, it's much easier to control it to wire the guiding. Now, snaring should be a final resort, not the first line. The reason is snaring is associated with certain difficult problems, like kinking the wire and getting the whole system stuck. So in the APCTO Club, we recommend snaring as a last resort. But we should also recommend how to snare safely. Now, the best way to snare safely is to push the wire all the way to the descending aorta. This prevents the snare knocking off plaque that will go up the carotids and cause a stroke. Usually the wire should already be in the descending aorta because you've tried pushing the wire as far possible to get the microcatheter across the CTO body. So get the wire down to descending aorta, and you can use the tubeless snare or end snare or some sort of snare. We prefer to use a homemade snare, the sort of Sumi 2G snare, where you put the tip of a wire inside a guide extension catheter with a balloon inside the guide extension to lock the tip of the wire, and the other end of the wire is outside the guide extension catheter, which means you can push it forward and pull it back to make a sort of self-homemade snare. Now, the homemade snare, if you want to know how to do it, there's a link in the description below. What you should do is you should snare the wire, but when you snare the wire, don't pull the wire into the antegrade guiding. Again, we should first try to use the snare to increase support so we can push the microcatheter through the CTO body. Then we can change for a softer wire, like a cyan black, which we can then snare and pull in the guiding, because a softer hydrophilic wire can release easily in the guiding. And if you use a homemade snare and you snare the soft sort of cyan black wire on the radio opaque part and you put it into the guiding, almost always you can release this. You can release the snare by deflating the balloon, and basically you just have a free wire. Okay, that's the advantage of the homemade snare. And then you can always, the system is not going to get stuck. Or you can even, if you get the retrograde microcatheter all the way to the ostium of the CTO vessel, you can even change directly for an RG3, and you can snare that and just pull it out. Okay, so those would be safer methods to snare. The danger, of course, is you snare a conquest wire and then you make a bend in it and you cannot release it, and then the whole system is stuck. So finally, rendezvous. And a lot of people argue, we don't need rendezvous. Why are you still doing rendezvous? But we do need rendezvous. And rendezvous is useful really for several situations. Number one is we cannot cross the CTO body with the retrograde microcatheter, even despite using an anchor balloon or even despite using a snare. The second is this inadequate length of the retrograde microcatheter. Now, some people say, oh, I never see this in my CTO practice. Well, go practice in Northern Europe. In Northern Europe, rendezvous may account for 30% of cases because the average height of the patient is 8 foot. So it depends on your patient group, okay? And thirdly, is for a rapid, rendezvous can be used for rapid establishment of antegrade wire access. In the case where you have some ischemia from the retrograde channel, or you have a donor vessel ischemia. And of course, for single guiding ipsilateral CTO, that's important. But we don't recommend doing ipsilateral CTOs with single guiding. So if we fail to cross the CTO body, and that probably is the most common reason why we want to do rendezvous, if we fail to cross the microcatheter through the CTO body, the wires cross, but the microcatheter won't cross, what options do we have? Number one, we can take out the retrograde microcatheter, put a small balloon, and try to balloon the CTO body from the retrograde side. Number two, we can change out for a rotational microcatheter and try to push hard. Number three, we can revert back and push a retrograde balloon up and do traditional cart. Number four, we can do antegrade external cap crush. We can knuckle wire antegrade subintimal and crush the cap and then see if the retrograde catheter is going to go across. Okay, and of course, number five, we can do rendezvous. Now, why is rendezvous a good idea? Because the other four methods are not very good methods. Trying to push hard on a retrograde microcatheter or a small balloon puts a lot of stress on the channel. Sometimes this causes channel rupture. Indeed, in the APCTO registry, this was some of the failed cases was caused by this, pushing too hard on the retrograde and causing channel rupture. So pushing small balloons and pushing rotation microcatheter is good to an extent, but there's a risk of channel rupture. There's also a risk of the fusion of the retrograde microcatheter tip with the wire, causing the whole retrograde system to get stuck. And that's not good. External cap crush sometimes works, sometimes it doesn't, but it's a lot of investment. You're doing a base, you're knuckling down, you're ballooning it, and it may not work. So this makes rendezvous quite an attractive method. Rendezvous might not work, but if rendezvous doesn't work, you don't lose wire position, you don't spend a huge amount of time on doing it. So to do the rendezvous, you wire the retrograde wire into the antegrade guiding. And on the biggest curve of the guiding, that's the point where the wires are going to point towards the outer side of the guiding curve. That's the best point to be able to wire into the antegrade microcatheter. Now, because if we're doing it for unable to cross the CTO body, that CTO body is going to be tough. So you want to get maximum antegrade pushability. So you're going to use a turnpike spiral or a turnpike gold, something that an antegrade can really get into the lesion and cross. And you're going to want to use a guide extension catheter or a side branch anchor balloon to maximum your guiding force. You're going to put the strongest guiding you can put on antegrade so that you get the push you need. You need good backup force to be able to get that antegrade microcatheter through the CTO body, because retrograde you cannot get across already, so it's going to be a tough CTO body. Another little trick I learned from Manos is that you can put a wire, even a Grand Slam, into the antegrade turnpike spiral. That's going to give the body of the turnpike spiral a lot more support, so you get more push. And then you keep drilling it across the CTO body, and then of course you can take out the retrograde wire and get antegrade access. If this doesn't work and you got the antegrade microcatheter down as far as you can, it's stuck somewhere in the CTO body, and you got the retrograde microcatheter up, of course, one other option is to do antegrade rotor wire tip into the retrograde microcatheter. So at that point, when the two microcatheters are near each other, maybe there's a little gap, you can try to pull out the retrograde wire and get an antegrade rotor wire to wire into the retrograde microcatheter, and then you can take out the antegrade and rotor. And that's a very powerful technique to be able to deal with a CTO body that you cannot cross. The problem with alternative methods of dealing with a CTO that you cannot cross with microcatheter is that it doesn't work well. You push too much of the retrograde gear, you use small balloons, you rupture the channel. You also stand a chance of fusing the microcatheter to the wire. And external capture doesn't work. So this method of Rendezvous to overcome this problem, it may not work all the time, but it provides a simpler, easier, and less time-consuming method to try to overcome this problem. So that's probably all the content in this paper. The link is in the description below. And it's a very important part of the retrograde procedure. Very small but important part. So I recommend the paper to you. And if you have any thoughts or comments, please leave a comment below. If you like, please click like and do subscribe for future content on the channel. We'll see you next time. Bye-bye.